Hello, this is Desiree Chappell. It's Tuesday. Welcome to the Roundtable, where we have in-depth conversation with the experts as well as those on the front lines of perioperative care.
Top Bed Talk.
So today we're sitting down with two very special guests. We have Dr. Lori Heller. She's a cardiac anesthesiologist with USA Anesthesia Partners at the Swedish Medical Center and acting instructor at the University of Washington in Seattle, Washington. Lori, thank you so much for joining us.
Well, thanks for having me.
Yeah, and we also have Dr. Bobbie Jean Sweitzer. She's a professor of anesthesiology and director of pre-operative medicine at Northwestern University here in Chicago. Thank you so much for sitting down with us today, Bobbie Jean. I'd really love for you to be able to kind of give us a little bit about your background, how you're involved in this space, and what you're doing to improve care through these different initiatives that you're working on. And I know that anemia is one of the things that you today, Lori, spoke about, and Bobbie Jean, you also can add to this as well, this conversation. So just give us a little bit about your background, what you've been doing in this space.
Sure. So I am a cardiac anesthesiologist, as you said, at Swedish Medical Center through U.S. Anesthesia Partners. I consider myself a recovering internist because I began my career as an internal medicine doc and then did an anesthesia residency, a cardiac anesthesia fellowship, and then have been practicing cardiac anesthesia. And I've been working with anemia since 2007 when we first established our anemia management clinic. And that really, it's been quite a different kind of journey, but we started actually with our treatment for bloodless patients and our interest in transfusion and lowering transfusion thresholds and taking care of these patients that were of the Jehovahs Witness faith. And that has since morphed with all the data that has come out about transfusion and now subsequently anemia. We've changed that and altered our path and really made our entire hospital a blood conservation hospital, and we do what we can to limit the amount of transfusions these patients receive, and part of that is by treating their preoperative anemia.
Wow, that's fantastic. I love the idea that it's grown into what it is and morphed into that and making a difference. So, Bobbie Jean, what is your experience at the preoperative optimization clinic where you are? Can you tell us a little bit give us your background and tell us a little bit about that?
Sure. So I'm also, a recovered internist. I trained in internal medicine. I practiced actually for about 5 years. And I used to do preoperative evaluations as an internist, and I did lots of clearances, and I thought I'd optimize my patients for anesthesia and surgery. And then I became an anesthesiologist, and I realized everything I'd been doing was wrong and insufficient. And Lori and I used to work together at the University of Chicago, and I had hoped that we could do lots of initiatives down there, but she ended up and left me and went back to home in Seattle. And she actually preceded my work with Anemia Clinic, and she's been a role model for what we've done. And she's been very generous, sharing a lot of her protocols and her experience. And I've been lucky enough to know Lori and work with her. And so we decided to start an anemia clinic, or I tried to, and I did that before at the University of Chicago, but it just sort of never got off the ground. And I came to Northwestern about 2.5 years ago, and the cardiac surgeons were the ones who actually were really pushing for this. And I think that's interesting because I think they have, they are big utilizers of blood, and they often have patients who are anemic. And so I think they've been leaders in this effort. So I reached out to Lori and borrowed some stuff, and then we started our own clinic. We did it a little bit differently, I think. We utilize embedded in our clinic. We don't use pharmacists the way Lori does. So I'll let her speak if you're going to ask her questions about the way her clinic is structured. But I adopted a lot of the same process and protocols and utilized that, but we took it a little bit differently.
Okay. Lori, can you speak to that? Kind of what does a clinic look like? How do you set something up like that?
Yeah, so there's now that they're established all over, they can look a variety of ways. We actually pretty much have a virtual clinic, which makes it much easier in our private practice setting where we have multiple physicians referring in. We have lots of different catchment areas. We're a tertiary referral center, but we treat patients from Alaska and Hawaii and Oregon and all over the place. So we have to adapt to that. So we have really a virtual clinic, and these patients get sent to us, and we have an anesthesiologist in our pre-op clinic and a pharmacist in our anemia clinic. The anesthesiologist oversees the pharmacist, but it's really protocol-driven. And the surgeons will refer patients to us. We evaluate them based on the laboratory. The pharmacist will call them for any additional information and set up a treatment pathway.
Oh, that's very cool. So what does the time frame look like on something like that? Because the number one question is, how can we implement an anemia clinic whenever we only see our patients 2 to 3 days, maybe a week before surgery?
Yeah, that's the struggle. And ideally, if we had a month, that would be wonderful for most patients. And it really depends on what their cause of anemia is and what their starting hematocrit is and what we're treating. But if we had a month, we would be very happy. But often we don't have a month. We might have a week. And a lot of times we end up delaying our surgeries. And so we delay the surgeries to get these patients treated and optimized, just like we would for hyperglycemia. And we do what we can. But in general, if we're treating with IV iron, we know that it really starts to work in about a week, and it takes 2 weeks to really get its peak effect. So if we can have 2 weeks, that would be great also. But again, it depends on where you're starting and what your goals are.
First of all, how did you kind of get buy-in from the surgeons, and how long did that take? And I'm sure it's still a work in process, right?
Yeah, years.
Oh, gosh.
And some, still.
What can we learn from you to help us improve
that? I'm not going to say it was an easy journey. I still had a surgeon yelling at me a month ago, in the pre-op area as I'm delaying his surgery for the patient with the big spine surgery whose crit came into 29.
Oh, my God.
It's not perfect. But the first thing we talked about in my talk is to get administrative buy-in. That's really what you need. You need someone behind you. You can't be the lone wolf saying, hey, this patient's hematocrit's low, we should probably do something about it and cancel the surgery. You really need administrative buy-in, and then you need department buy-in, and you really do need to get that surgeon's buy-in. And you do that with data and education. They will be receptive if you show them the data is overwhelming. And the other thing that we really advocate is not adding an extra work burden to their day. They are full, and so they don't want to deal with that. So we set up protocols and ways that you don't have to do anything. Just tell us about your patient. Just let us know this patient is out there. We will take care of the rest. And once we can let them know that that is the case, then it's usually an easier pill for them to swallow.
Yeah. Bobbie, has that been your experience too? First of all, I guess tell us what your clinic looks like and maybe the difference between the two, and then a little bit about that experience, because people are dying to know that information.
So Northwestern is a larger healthcare institution than just the downtown campus, which is the main academic tertiary care. There's, I believe, now 5 other hospitals scattered around the periphery of Chicago, and we are one big consortium. So we also work very closely with those hospitals so that if patients are better served at their local institution, we work with them. But it's our general protocol that we've developed. And then likewise, because we're a tertiary center, we see people from coming out of the country being referred in to us. So we've just worked really hard on that education piece and data piece, the way Lori mentioned, to get that information out to surgeons, either who are not aware that anemia is such a big deal. We've also really tried to reach out to a lot of our primary care physicians, because if they can identify these patients before they refer them to surgery.
Yeah.
And again, so we do a lot of outreach and a lot of education. And we are lucky enough also to have a fairly robust data gathering system, so we can feed back to them the number of patients being transfused, the average hematocrits of patients when they come in, when they go home, the average blood loss of patients during surgeries. We probably are seeing, the patients who benefit the most earlier now, as early as sometimes even, 5-6 weeks before surgeries, the major joints and major spines, and some of even the cardiac patients. So that has really been fabulous, because then that really gives us a lot of time to get those patients prepared. But even if the patients, are coming in a short time before, we've noticed this sort of psychological bump in surgeons' perspectives about not transfusing and anesthesiologists' perspectives about not transfusing. And I think it's because, and I hear this all the time even in the hallways, they're like, but the patient got iron, so they'll be getting better. Their hematocrits will be going up. So I think we can live with this, 7 or 8 or 9, where before they would be like, well, the patient's going to go home. They're going to be tired. They're going to complain. They're going to have decreased wound healing. They may bounce back to the hospital. So let's give them a unit of blood.
Yeah.
Even without sometimes enough time to have shown a significant change in their hemoglobin, I think they're feeling like we've treated this underlying condition. It's just now a matter of time to see those effects.
So it seems like we've done something. They want some intervention, right? Because anemia is uncomfortable for everyone, right? The patient doesn't feel good. The nurse doesn't feel good. The doctor doesn't feel good. No one feels good when someone's anemic. And so if you can actually do something, I've given them this IV iron, I've actually made an intervention, I've done something, then everyone feels better. It's sort of like, Bobbie, I don't know if you noticed, but in my practice, when a patient would come in with something, and if you didn't send them out, a lot of times you felt like you had to send them out with a prescription, right? That would make them feel better. And so what we did then is we just just wrote up a lot of patient handouts. So at least you could physically give them something about their URI that you didn't have to give them that prescription for amoxicillin. You physically gave them something, and everyone felt better. Yes, everyone felt better. They just want to have something. We want to be feeling something.
Yeah. Right. I mean, even, conversations that you have with patients and educating them as well, I think the patient is more satisfied. Even though we believe, like you do, that oral iron is not appropriate preoperatively, we do believe there's a role for that postoperatively, particularly for those patients that, surgery is a short time. We can give them maybe one infusion, but we can't fully replete their iron ahead of time. We want those patients to go home and start taking oral iron to supplement that and then take that in the postoperative period. And so I think that, it's just raised the specter of people actually talking about it and identifying it and not just letting it slide through, not just accepting that it's okay for somebody with a low hematocrit or hemoglobin. And then there's all this unintended consequences that as we identify these patients who should not have iron deficiency anemia and then encouraging them, we've saved to have evaluation. We've had probably 2 or 3 patients just in the last year who turned out to have colon cancer, who were scheduled to have joint replacement surgery. And in the past, those patients, and I had a couple of those in the past, would, have come in, had their joint replacements, been started on an anticoagulant, warfarin, because they typically take that for a few days to prevent DVT, and they have a GI bleed.
Yep.
And now they've got an acute GI bleed and acutely diagnosed with colon cancer just right after joint replacement.
Turns into a huge disaster.
Right. So I think, we're just making everybody aware that anemia is not something that's acceptable. And we need to identify it as a problem, realize the risk. When we can, institute treatment. And when we can't, fix it before surgery, that it still needs to be followed up on.
Yeah.
And the other thing with that is that patients, they're getting identified before their surgery. So before, what would happen is they'd have their surgery, they'd present to their doc, they'd have their iron deficiency anemia. The doc would say, oh, it's because you just had surgery.
Yes.
And then you'd wait. So there's a delay in that whole diagnosis. So we're really impacting these patients in a positive way.
Yeah. After hearing your presentation this past spring, in the way that you presented it and what you had talked about, anemia is a big deal. So how treating it, if we can get a hold of it before and treat it before, what kind of difference are you actually seeing in practice?
So we see a decrease in length of stay. So a lot of these things are difficult to measure in a private practice hospital on a long-term basis, but we have seen the measurable things that we look at in administration, decreased length of stay. The other thing that we've shown with our orthopedic patients is they're more likely to go home as opposed to a skilled nursing unit, which is a big impact for our patients and for society in general. Yeah, their transfusion rate is lower. We've looked at, in our cardiac patients, we've looked at ventilatory requirements, staying in the ICU, post-op infections. All of those things are measurable and significant.
Bobbie Jean, have you guys looked at patient satisfaction or anything?
That's really fascinating because that's exactly what I was thinking as Lori was, answering, because we've seen some of those same things that she mentioned. But we saw a significant increase in patient satisfaction. And in fact, in the comments section, frequently the patients noted about the anemia clinic and their iron infusions. And they would remark on things like, I've had surgeries before and nobody ever evaluated me to this extent. Nobody ever treated me. I've had anemia for 30 years.
Oh my gosh.
No one's ever offered me this option. I had to have a blood transfusion with my previous hip. I didn't have a blood transfusion. We were just going over because our satisfaction scores, particularly from our clinic, had this huge bump in the last year. And many of the comments were directly related to the iron infusions and the anemia management. It was interesting.
That really is. And to know that we can affect all these different things, but really a tangible improvement that a patient can see, that's huge. And it probably helps to drive implementation of all of this and acceptance of it.
Yeah. We had one patient, I remember very, very clearly, that she was having this abdominal pain, and they were going to take out her gallbladder because she's been having this abdominal pain for a while. They couldn't figure out, it must be that. And then we treated her anemia, and she felt so much better. She said, I don't think I need surgery. My belly, I just feel so much better. I have more energy. And that was it. And she canceled her surgery. So...
yeah, that's amazing. I love that. Just the fact that we can do what we do and maybe sometimes change something and prevent another surgery, that's great.
The other thing I'd like to mention is, Lori mentioned briefly about patients who refuse blood transfusions, like particularly those of Jehovah's Witness faith. And we had some major issues, and the Jehovah's Witness community here in Chicago had actually reached out to the Northwestern community because they felt that they were not having an opportunity to have sometimes more sophisticated, extensive surgeries, some of the cardiac procedures, some of the joint replacement, some of the major spine, and some of the transplant procedures because of their unwillingness to accept blood. And many of them are anemic as well, or some of them aren't, and we just want to have their hematocrits super normal. And so we've had a really good interaction over the last maybe year and a half with that group. And the unintended consequences of that too is that we believe it's helping us also decrease just blood transfusions in general for surgeries in patients, because as the surgeons and the anesthesiologists are now taking care of more of these patients because of their choice of not receiving blood, end up with quite low hemoglobins and hematocrits sometimes, and yet we can take care of them and do it safely. I think that's helped them accepting lower transfusion triggers for all patients.
Yeah, that's fantastic. So the way that your clinics are set up, I've kind of heard, is that it's driven from anesthesia-based clinic, and that's how it is. Have you seen other models that other providers, other types of providers, other physician groups, hospitals, how they're coordinating their clinics and who's driving that?
It's really fascinating, I think, because as a former internist, you would think that this would be the purview of, internal medicine. This is bread and butter, anemia. But it has not, I don't think. I think it's been interesting to see that it's primarily driven, I see it, from surgeons and anesthesiologists recognizing this. In fact, some of our patients who were not getting iron infusions, who needed them the most, were the inpatient group. That would be a patient who comes to the emergency room, for example, with, maybe a small bowel obstruction or something. So they're admitted to medicine often to see if they can't medically treat their small bowel. And they come in, they're anemic to start with. They're in the hospital now for a week or 2 weeks. They keep drawing blood. As, Lori mentioned that in her, talk about how patients could just get, phlebotomized.
Oh my gosh.
In fact, I think it's an average of, 1 unit of blood a month.
4 to 5 days.
Right, exactly.
In the ICU,
Exactly, in the ICU, just from blood draws. And so we reached out to the medicine service and the hospitalists who are taking care of those patients and said, the minute you see these patients, realize that they may be going to surgery. So, we did it because I think it was politically more acceptable to do it that way than us trying to reach out and tell the medicine doctors how to practice, And so, they may be going to surgery. So let's give them some iron now, because while they're waiting, it'll benefit them if they don't have surgery, and it will definitely benefit them if they end up failing the medical management and they need to have surgery.
Sometimes you got to work all those angles.
Right.
We actually tried to get our hospitalists to do this instead of anesthesia, and there was just no interest.
That's
and that's how I started the anemia clinic at Northwestern, is because the cardiac surgeons had been trying to get the hematologists to do this for a number of years. And the clinic at Northwestern, the pre-op clinic, was previously run by the hospitalist medicine service, and they had not wanted to implement an anemia clinic.
So what is your relationship now? It really is. What is your relationship with the hematologist now? I mean, how has that kind of changed the conversation for you all? Bobbie Jean, do you want to?
Yeah, I mean, we've had an excellent, at the very beginning when we decided to do this, I reached out and we partnered with a hematologist. I met with 2 or 3 of the benign hematologists, or the ones who typically will take care of somebody with just, basic anemia. And they welcomed this with open arms because they felt like they were understaffed. They felt like they were struggling. They felt badly about not being able to see these patients preoperatively. They just didn't feel like they had the bandwidth to be able to manage them. Yeah. The infusion clinic that they were using also was giving chemotherapy and a lot of other antibiotics to people with long-term infections and whatever. They felt completely maxed out. So we've had absolutely no pushback. They've been, in fact, ironically, sometimes they're referring patients to us to get their iron infusions because they know that before they refer them to the surgeons, or they know that they have patients who are likely to have surgery at some point, because we have kind of kept it to this point as pre-surgical, though even just a month or so, I've started opening it up more to patients who are, post-op, and patients who are post-op, even they've gone home now, but they've come back even to their primary care doctors and still anemic, and even patients who are not planning surgery, because we have the capacity right now to absorb more patients, and the infusion clinics and the hematologists are just overbooked and overwhelmed.
Yeah, and the benefit just for overall population health. I mean, I just think it's a great answer for that.
Yes, and then it also gets that message out to the internist and to the hematologist, again, that this is an issue Iron is available. I think there's a lot of also misconceptions still about, the preparations. When IV iron was first available, there was concerns about the risk of anaphylaxis. It was often poorly controlled. Patients had chest pain. They felt short of breath. They made them sort of not feel good as they were getting it. It was relatively expensive. It was relatively difficult to get insurance companies to pay for it. So I think that people, a lot of the, internists and the other doctors had that concept that this was just a impossible or difficult thing to do.
Yeah.
And so I think we've changed their perspective on that.
And transfusion's an easy thing to do because every transfusion, because in infusion center, it's so easy. They're used to ordering 1 unit, 2 units. They go and get their transfusion and they're done. Yeah. And there's no follow-up really, right? With the IV iron, you got to make sure, is it repleted? Are they responding? Whereas you give a couple of units, it's much easier to do.
That's the other fallacy about transfusions. People think that if you transfuse someone, you're giving them iron, but you're not. There's actually a very small amount of iron in a unit of packed red cells. And, when you transfuse somebody, you mentioned, I think this morning, how like this is old blood, it's been taken out, it's been in the refrigerator. Some of that blood is not sticking around very long, but the half-life of red cells is relatively short anyway, right? It's measured in weeks to a couple of months. So it isn't treating their underlying problem. It's a Band-Aid anyway, right? Yep. And so if they have ongoing blood loss or ongoing, if we haven't really repleted their iron, they're still going to be anemic now. You just bumped up momentarily their hemoglobins.
And if you don't follow up, you don't know what the root cause of it is.
Or that even they go back down and they're anemic again.
Yeah. Right. All right, final question, ladies. Thank you again so much for sitting down with us and spending the time. So I talk to a lot of people that would love to have something like this, and they just don't have resources. But they may have a PAT clinic. They may have a little something. So what are you suggesting, or how would you consult someone that wants to do it? They see a need for it. It can be revenue generating. How do you talk to those people that want to do something like that with limited resources?
Yeah, so I would say start small, and a good place to start, concentrate your efforts, and a good place to start are your orthopedic population. Gotcha. So these elective hips and knees, they have a set DRG, it's a set surgery, usually has a set amount of blood loss. You can track these patients, you can follow these patients, you can get buy-in from one department, and the benefits are so great, and they'll see that, and then that's how you branch out to other aspects. The other place you can start, too, with iron infusions are in your OB population, because everyone's iron deficient there, and treating those patients has immense benefits for the mom and the baby, and so that works, too. But I say start small. You got to get administrative buy-in. You got to ramp up your infusion center, but starting that way, it's an easy way to branch out.
Yeah, that's great. Bobbie Jean, a final thought?
So I second that as well. The only other group that we have opened up our anemia clinic to broadly is the pregnant patients. So we will see any pregnant patients and give them iron. But we have to be careful because the different iron preparations have different classifications for pregnancy. So you want to be cognizant of that. But I think, again, the orthopedic group is perfect because they're also relatively elective surgeries, and they often book very far out. Yeah. And so they, you have the time and luxury of that. I think, try to partner with a hematologist if you don't know much about iron and anemia and that sort of thing. I think, again, many of these hematologists find it so onerous to try to squeeze in patients for surgery and manage them that they will usually share resources. I think visiting a clinic, we have visitors that come and see our clinic. We share our protocols with them, and we're happy to do that. Coming to lectures like this, joining organizations like this or SPACI that, have people who are doing this kind of stuff. It just grows. It's like we all help each other. And just like I learned so much from Lori and took a lot of her stuff, I'm happy to pass that along and share, and many of us are.
Wonderful. Well, ladies, again, I just really appreciate it. Thank you so much for sitting down with us at Top Med Talk. Look forward to many great conversations in the future with you guys. Thanks so much.
Thank you.
Top Med Talk. Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.